Good evening. Thank you, everybody, for joining us. Hope everyone gets some food. We are going to try to keep everyone awake and entertained. I know at this point of the meeting, the days start getting long. We can feel it. I'm sure you guys do too. So welcome to Peer Review. We're going to be talking about mastering the art of precision in the treatment of hormone receptor positive, early, as well as metastatic breast cancer today. I'm Erica Hamilton. I'm at Sarah Cannon Research Institute in Nashville, Tennessee, and I'm joined by a fantastic faculty. To the right of me is Hope Rugo from UCSF. And to the right of her is Kamal Jhaveri from Memorial Sloan Kettering in New York. And all the way across the stage is Paolo Tarantino at Dana-Farber Cancer Institute. We look forward to speaking with you tonight. So thank you to both our in-person as well as the virtual attendees that are joining us from their computers. PeerView, GRASP, as well as Living Beyond Breast Cancer for providing this education session. And we paired with some patient advocates to have their voice heard in this session as well. And to AstraZeneca, Lilly, as well as Olema Pharmaceuticals for providing the educational grants that made this session possible. If you haven't already, please complete the pre-event survey. It really helps us. There is audience polling throughout the program. Many of you will have an iPad in front of you that you can do the audience polling on. If you don't, you can scan this QR code and do the audience polling from your phones. And please submit any questions. We'll try to get in as many questions as we can throughout the program as well. You can also view the slides and the practice aids and download them after the event. So if there's something that we flip through too quickly or you want to see again, you'll have the ability to get this. So our goals for today are to augment your knowledge in the evolving clinical roles of standard, new, and emerging treatment options for hormone receptor positive breast cancer, really talk about sequencing these agents, and enhance your ability to provide education to patients. And again, we partnered with both GRASP as well as Living Beyond Breast Cancer.
Timer is already on.
Okay, so first we're going to be talking about navigating the evidence and clinical decisions and implementing strategies to reduce the risk of recurrence in the early setting. So this is our first case. This is a 45-year-old premenopausal woman. In July of 2022, she had a mass in her right breast that she noticed. Mammogram and ultrasound showed a 4-centimeter mass, and she also had a suspicious axillary lymph node. Core needle biopsy revealed high-grade, grade 3 invasive lobular carcinoma, strongly ER/PR positive, HER2-0, and Ki67 in the 15 to 20% range. She does have the axillary lymph node biopsy, and it is positive for cancer. She ends up having staging scans that are negative. She also has panel testing that's negative for BRCA alterations. She undergoes surgery and ends up with 4.3 centimeters of grade 3 invasive lobular carcinoma with 1 out of 3 positive lymph nodes. She receives adjuvant dose-dense AC followed by 12 weeks of paclitaxel, has radiation to her chest wall and to the regional lymph nodes. And so our first polling question, you're going to answer it now, and then we're going to come back and discuss it a little bit later, is would you recommend treatment with an adjuvant CDK4/6 inhibitor for this patient? 1 and 2 are yes. 1 is yes with abemaciclib. 2 is yes with ribociclib. 3 is no, I would do endocrine therapy alone, and 4 is I'm not sure. And you can answer this on your phone or as well as the iPad. Okay, we have most people saying that they would pick adjuvant abemaciclib. Adjuvant ribociclib comes in next, and the minority saying that they would do endocrine alone, only about 11%. Okay, so next up is Dr. Rugo. She's going to talk to us about adjuvant CDK4/6 inhibition.
Great, thanks very much, and excited to see everybody here this evening after our, I think, really great first day of scientific presentations at San Antonio, much more to come over the next 2 days. So we're going to talk about adjuvant CDK4/6 inhibitor, and of course, the key trial for all of us is Monarch-E, where a large number of patients, as you can see here, almost 5,700 patients with high-risk early-stage breast cancer, were randomized to receive, along with their standard adjuvant endocrine therapy, And that could be whatever physician's choice was, abemaciclib or not. And there were two cohorts. So the first cohort were patients who had at least 4 or more positive lymph nodes, or if they had 1 to 3 positive lymph nodes, they had to have one of 2 features, grade 3 disease or a tumor size of 5 centimeters or greater. Then there was a small cohort really directed towards investigating an area we'd been interested in for decades, actually, which was how does Ki-67 affect response to endocrine therapy, to targeted agents, and prognosis. So that group, 9% of the total population, had 1 to 3 positive lymph nodes and centrally confirmed Ki-67 of 20% or greater, but they couldn't have grade 3 disease and they couldn't have a tumor size greater than 5 centimeters. The treatment duration was 2 years, and the primary endpoint was invasive disease-free survival. And then, of course, to look at this in the high Ki-67 population was a secondary objective. As you know, we've been reporting data for monarchE since we had our 2-year follow-up. So there was follow-up at 2 years, and then a little bit longer, and then 4 years and 5 years. So the most recent follow-up presented by Nadia Harbeck at ESMO this year, just 2 months ago, was the 5-year overall efficacy analysis. So the data cutoff was in July of this year. So now we can really look at IDFS and distant recurrence-free survival, but it's also really important to keep in mind that overall survival is very early to look at overall survival for a patient population with hormone receptor-positive disease. So median follow-up, you can see, is 54 months, and all patients are long off of abemaciclib. It was only 2 years of therapy, and more than 80% of patients were followed for at least 2 years after finishing abema, which means it's a really big population now. So here you can see in the red is the 2-year course of abemaciclib, and you can see that the curves start to separate shortly before 24 months and continue to separate over time. And to me, the most remarkable aspect of this data is the increasing degree of benefit over time, suggesting a carryover effect that exposure not just to endocrine therapy, but to a targeted agent, a CDK4/6 inhibitor, early could still be reducing recurrence 3 years after finishing treatment. So now the delta in IDFS is 7.6%, hazard ratio 0.68, highly statistically significant. It's a nominal p-value, less than 0.001, and you can see the IDFS events are more in the patients who received the standard endocrine therapy. And then if we look at selected subgroups looking at IDFS, you can see that all of those diamonds really line up to the left of one. So this is, I think, shows you that all of the different subgroups benefit. And the only subgroups where there wasn't clear benefit were really very, very small groups where you really couldn't tell exactly what the impact was. But I think that's so encouraging when you see it didn't matter whether you were taking tamoxifen or an AI, whether or not you had stage 2 or 3 disease, what size your tumor was, et cetera. Now, the other really important endpoint, and I think probably the most important endpoint for oncologists, is distant recurrence-free survival. We don't like our patients to get metastatic disease. And here you can see that, similar to IDFS, the difference continues to increase over time. So you can see it beginning 2.5%, now up to 6.7%, with a hazard ratio of 0.675, a lot more events in the patients receiving endocrine therapy alone. Again, a nominal p-value of less than 0.001. I think it's encouraging for all of us to see that the curves are continuing to separate. Now, overall survival, still not enough events. What does that mean? It's great for our patients. Patients are living longer now than ever before who have hormone receptor-positive metastatic disease. So that's not a downside. But of course, we want to see overall survival benefit when we're giving patients 2 years of a CDK4/6 inhibitor who have high-risk early-stage hormone receptor-positive breast cancer. So one endpoint that we found, which I think is very interesting, is fewer patients are alive with metastatic disease who are in the abemaciclib arm. And that's depicted in these bar graph in the green-colored bars. So less patients alive with metastatic disease, deaths due to breast cancer. If you look at the overall survival at the interim analysis 3, which is the one we were talking about at ESMO, you can see there are numerically less events. But these numbers are still very small, thankfully, and a small number of patients died for other reasons, thankfully no difference between the arms. Now, one of the things that we're really interested in is the impact of Ki-67. So I'm not showing you that here due to time, and also that wasn't a main point of the ESMO presentation, but it was shown at the last presentation update, which I think was at San Antonio last year. And Ki-67 is clearly a prognostic factor. There's worse outcome in patients who have high Ki-67, and 20% seem to be a reasonable cutoff based on previous studies and now defined here. but it didn't impact the benefit of abemaciclib. Hazard ratios are the same. Abemaciclib worked equally well whether you had a high Ki-67 or low. And you can see that here in cohort 2, very much smaller numbers in cohort 2, but similar benefits in terms of the IDFS and the DRFS. If you look at the hazard ratios, they look a little bit different, but the number of patients in cohort 2 is small, and the follow-up actually is a little shorter in cohort 2 because we enrolled that last. What about safety? Well, good for all of us to know that if you take 2 years of abemaciclib and you stop it, all the toxicity goes away. So there's no long-term toxicity, no new safety events. So that's actually really good. We don't see long-term toxicity from these agents. So based on this data, actually, and the data actually from 4 years, which was before this presentation, so from San Antonio last year, the FDA changed their tune a little bit. They had originally approved abemaciclib only in patients who met the study criteria and had a Ki-67 of 20% or greater, but then they could see with longer follow-up that Ki-67 was not a factor that predicted benefit, so they took away that requirement. So now really you can use abemaciclib in patients who would qualify for the Monarch E trial, so that's very helpful. Now, we have a second trial that has reported positive data. This is great situation for our patients with early-stage hormone receptor-positive disease, ribociclib. So the NATALY trial actually looked at 2 different things. So one is to extend out the exposure to the CDK4/6 inhibitor to 3 years versus 2 years, and then to use a lower dose of ribociclib than was used in the metastatic setting, where more than 50% of patients required dose reductions, and dose reductions didn't impact efficacy in a very nice analysis. Also, because of the QT prolongation and drug-drug interaction with ribociclib, you could only receive letrozole or anastrozole, and tamoxifen was prohibited, as was exemestane. In fact, one of my patients changed to exemestane with her outside doctor, had to go off study. So the idea was not to sort of get difficult situations that we couldn't manage in terms of toxicity. The eligibility also was broader, so they wanted to include a patient who had node-negative disease. These patients had either had grade 2 histology and a high either oncotype DX recurrence score, high-risk genomic risk profile, or a high Ki-67 of 20% or greater, or grade 3 histology, and then anybody with node-positive disease was eligible for this. And then what they did at when the trial was nearing completion was add on 1,000 patients who had higher risk features because of the Monarch E results to try and really power this to see a difference if patients had a higher risk of recurrence. So patients were randomized to ribociclib and then their nonsteroidal aromatase inhibitor, and patients who were premenopausal, just like the Monarch E trial, received ovarian function suppression with a primary endpoint of IDFS using STEEP criteria. So as Dennis Slayman presented at ASCO this year, NATALY met an IDFS endpoint. And interestingly, it met this endpoint when only 20% of patients had completed 3 years of therapy, which of course brings up the question about the optimal duration of CDK4/6 inhibitors, which we're not going to know the answer to. But you can see here that the hazard ratio is 0.748 and a p-value of 0.0014 with an absolute benefit at 3 years at 3.3%. At this meeting, NATALY will present updated data with an additional about 6 months of follow-up. At this time, it was about 34 months of median follow-up. But again, a lot of people are still on treatment, and there will be more people off treatment now. They also showed a significant distant disease-free survival as well, a slightly lower delta. As you would expect. So now across clinically relevant subgroups, these are the absolute differences. This is a little bit hard to read because it's not a real forest plot, but it shows you the hazard ratios on the far right-hand side for you, showing that across all of these different subgroups, you're seeing similar hazard ratios. That's really what you should look at. The one thing I will say is there's a smaller number of patients with node-negative disease, and those hazard ratio, the confidence interval crosses 1 in a number of these different categories like stage 2 disease, not in stage 3 disease, and that really just has to do a short follow-up. We need longer follow-up to see what's happening in that patient group. And then they used 400 milligrams, so there was a big interest in whether or not there was less toxicity. Indeed, there was a little less grade 3 or greater neutropenia, and importantly, less QT prolongation, although it was still seen, and no difference in ILD pneumonitis. One of the issues that required holding drug and even discontinuation was liver-related adverse events with transaminitis, and that was the most common cause of discontinuation of ribociclib. And here you can see that there are still liver-related AEs at 400 milligrams, although holding the drug and dose reducing has been effective in a variety of settings. So I'm going to hand it back to you to the case.
Okay, so we aren't going to go through it completely again, but again, 45-year-old lady, 4-centimeter mass, grade 3, high grade invasive lobular carcinoma, Ki67, 15 to 20%, positive lymph node, and she ends up with 4.3 centimeters disease, AC to T, has radiation. And so this is a little bit of something for us to discuss. This was patient experience survey findings. This was polled for Living Beyond Breast Cancer as well as GRASP and peer review patient experience. And the question was, if you've been diagnosed with early breast cancer, has your doctor or another member of the cancer team discussed the risk of recurrence of your breast cancer with you? And you'll see we're not doing a horrible job. 61% said yes, that was clearly discussed, and it helped me understand my risk and what my options were. 22% said yes, but I didn't really understand that risk of recurrence. And 16% said no, I don't remember. And I think risk can be particularly hard for patients, right? To understand, well, what is a 6% risk benefit? Any tricks, Kamal, of how you explain this to patients to make it a little bit more actionable?
Well, I do believe that absolute numbers helps. And in particular, every time we decide to utilize or not utilize a drug, we're balancing risks and benefits. And of course, I think both discussing the benefits in terms of percentage, but also absolute numbers helps with the patient. And so try to figure how much of the risk of recurrence you can cut. And one challenge I find is that the risk of recurrence, we know that is on a long time. We know that patients can recur over 10 or more years. And so I think you need to create a cut point for that. And I would love to hear how Kamal does this and what cut point you utilize for patients when you discuss the risk.
Yeah, I mean, I think, it can be challenging because there are so many things that we can use as examples for risk reduction. It's not just the adjuvant CDK4/6 inhibitor we're referring to here. For a high-risk patient population, we're also bringing in the flavor for adjuvant chemotherapy and what benefit that might bring in. Sometimes when we have the genomic risk scores, that can be very helpful. I usually print them out. I actually, sketch it out and talk to them about the numbers that are printed out and then explain what the benefit from the adjuvant endocrine therapy and the addition of chemotherapy would come from. And then talking about absolute numbers with the addition of adjuvant CDK4/6 inhibitors. And then many a times with this high-risk patient population, we also use, bisphosphonates and bone-modifying agents to further highlight. So I think it also becomes a little easier. I think the context about the higher the risk, I think sometimes the perception and the threshold for what that risk reduction would look like from a patient perspective is also there. For a lower risk patient population, it might be a little trickier to justify something. So that risk-benefit ratio of toxicity is also a very important discussion to bring in with the efficacy.
Yeah, I think those are great points. I think sometimes it's trickier with ER-positive breast cancer because that risk goes for so long.
Yeah.
So you don't want to scare people, but the reality is that they can recur very late, right? And so this decision that they're making now can really impact things for quite a bit away. What about you?
Yeah, I mean, I think that we do talk to people, but I think, you want to balance it between scaring people and advising them correctly.
Yeah.
So it's hard. I mean, it's easy for stage 1 disease. We use RSC Clin on the, we can go in and show people. Even then, it's sometimes really shocking for people what the risk is. So you have to kind of comment on the fact that these aren't perfect or individual. But for patients who have multiple positive nodes, it's a really big issue. And I do talk about recurrence risk and that it's very long in duration. And I think the other things is, once we've made the decision already, we've made chemo decision, right? We talk about the fact that, we can rescue with CDK4/6 inhibition now. We'll give endocrine therapy. And I have to say, I have occasionally continued the abema after 2 years in a very high-risk patient, very high risk. You have these people with 10 positive nodes, and so it's hard to stop. And it's hard to stop the AI. But we also talk about things that patients can do themselves to try and mitigate risk. Trouble is, a lot of my patients are, exercise all the time, aren't particularly overweight, they don't smoke cigarettes, they're not drinking a lot of alcohol. But I think we can talk about things that patients have some control over. Continuing those activities is one thing.
I think the one thing that I would add is like when we have these conversations and initial consultations with our patients, when we're going over this whole slew of
Don't do it all.
treatments, when you do it all, it's really overwhelming and scary. And so bringing that up again at the next follow-up to try and see, is there anything that you want to look at? And giving them patient materials on adjuvant endocrine therapy or the chemotherapy they're going to get or adjuvant CDK4/6 inhibitor, and bringing that conversation back in the follow-up appointment sometimes can give a sense. So what did you understand from our conversation from last time? Is there something more that you would like to discuss? Perhaps those kind of
Multiple
strategies
times.
help, because it's a lot of overwhelming information.
Right, and then reminding again at year 1, 2,
And 2, 3. Wait, I didn't know anything about the CDK4/6 inhibitor.
Okay, so what adjuvant endocrine therapy would you be thinking about for this premenopausal patient that was lymph node positive? Dr. Tarantino, maybe we'll go down to you. Ovarian suppression AI, ovarian suppression tamoxifen, or tamoxifen alone?
So we're talking of a premenopausal patient and a high-risk tumor, node positive with high-risk features. I do believe that ovarian function suppression is important in this case. And it comes with side effects, and it is important, of course, to discuss with the patient, but at the same time, we know that the soft and text trials showed a meaningful, both statistically and clinical advantage by the addition of ovarian suppression. And we also know that AI are superior to tamoxifen. In that case, I would definitely try ovarian function suppression and AI, knowing that if the regimen is not well tolerated, there's many strategies that can be utilized, including changing the type of AI. It often happens that if you utilize a non-steroidal aromatase inhibitors, you can change it to a steroidal one with benefit on side effects, or even utilize tamoxifen, because we also know that ovarian function suppression plus tamoxifen is superior to tamoxifen.
Great, well said. Dr. Jhaveri, would you offer adjuvant CDK4/6 here, and if so, which one?
Yeah, I would. I think given the high-risk nature of the cancer, I think I would. And right now, I would go with abemaciclib because that's all we have approved at this point, and the maturity of the data speaks for itself in terms of our comfort level for understanding the efficacy benefits that we have. Certainly, we discuss the toxicity profile with the patients and make sure they understand what we can do to make it better.
Dr. Rugo, I'm going to throw the difficult question at you. Say we get approval of ribociclib. How are you going to decide who might get abemaciclib versus ribociclib?
I think that we're likely to get approval for ribociclib when we have a little bit more data, is my guess. And that little bit more data may help us make decisions. I mean, on the one hand, you have a drug which doesn't cause diarrhea, but you have to monitor liver function tests, and it's a year longer to see the benefit. So I think you just have to talk to patients about it, and we are going to have the data from all of that in order to discuss it. I think, we had talked about, would we give abema for higher risk patients versus lower risk? But, there were plenty of higher risk patients in NATALEE too. So I think it's really going to depend on the robustness of the data and looking at what we have when we do have drug approval, which isn't yet. So
Yes, absolutely. Okay, so this case continues. So our patient does go on an LHRH agonist with letrozole. She also receives adjuvant zoledronic acid and abemaciclib, 150 milligrams BID. So our poll here, with the original case, what are you thinking in terms of what you would recommend? Any changes from your initial answer? Okay. So we have less people saying that they're not sure, and less people saying endocrine therapy alone, and we have more people picking abemaciclib. Certainly some people still picking ribociclib for CDK. I think that's very appropriate.
Yeah, and I think that if somebody didn't tolerate abemaciclib and had bad grade 3 diarrhea, and you keep trying and you can't make it work, you have a good alternative.
Exactly. Okay, so this case continues, and speaking of diarrhea, this lady has grade 2 diarrhea for several weeks, and then kind of more mild grade 1 diarrhea that continues. She's struggling a little bit with fatigue. Neutrophil counts are doing okay, 1.8. She's taken a couple 6-week breaks off of therapy. She remained on letrozole and her LHRH. Diarrhea and fatigue do improve off therapy. She's kind of anxious about continuing her abemaciclib. She's anxious about discontinuing. She's struggling. She's not really sure what to do. where would we go from here? So briefly, this is a little bit of data about abemaciclib dose holds and reductions as part of the study. So we see that 42% of patients on study actually did have at least one dose reduction. And so I find this number very helpful when I'm talking to a patient, because people really struggle about, well, if this drug is going to be beneficial for me and I take less of it, does that mean that I'm hurting myself? And to say, well, in the trial where we saw this benefit, in fact, almost half of people did have to have a dose reduction. So, this isn't abnormal. There's nothing wrong with you, right? And mainly that these dose reductions were due to diarrhea, less frequently neutropenia and fatigue. So factors associated with increased risk of treatment discontinuation was certainly our older patients, similarly postmenopausal, that goes along with that. 1 to 3 positive nodes instead of 4+ positive nodes. So perhaps this indicates that people that really felt that they were at higher risk, really tried to make it work, but lower risk patients thought that the risk-benefit ratio was a little bit different. And those patients with more comorbidities. So, those that may already be struggling with health conditions at baseline. So this was a analysis looking at relative dose intensity. So in relative to the original prescribed dose, how much of the abemaciclib were patients taking, and did that impact how they did? So you can see these 3 different colors, 0 to 66%, 66 to 93, and greater than 93. And you see that even for those patients that did dose reduce, that it really looked like invasive disease-free survival rates were similar across these groups. So I think, we now have a little bit of data to say, yes, people did have to reduce on trial. And in fact, when we look at people that had dose reductions, it didn't look like they did any worse than those who didn't. And we have to remember, that this is a flat rate dosing. It's not weight-based, et cetera. And so some people really may be getting exposure to the drug that's different from somebody else. And so we need to make sure that it's tolerable for the individual patients. What about the question of our older patients? And so you can see the age split here is less than 65 years of age compared to 65 and older, and you really see similar benefits. And so I think this gets at the question of some people saying, well, I think my older patients have cancer with better biology, and so they may just not need this. So it really appeared that when you select for these high-risk characteristics, the grade, the tumor size, the number of lymph nodes, that even our patients that are older benefited from adding adjuvant abemaciclib just as much as our younger patients did. And then what about safety? Safety looks pretty similar. A couple of exceptions. We don't see a whole lot of differences in neutropenia. We do maybe see a little bit less diarrhea overall, but more severe diarrhea. So 7% versus 12% in the 65 cutoff. But overall, I think our older patients certainly are able to tolerate abemaciclib, and I think this is a drug that we certainly can use dose reductions if needed. Dr. Rugo, how do you typically manage diarrhea for abemaciclib? Is there anything you do prophylactically? How do you counsel patients?
Well, so I talk to patients right up front about the diarrhea because, my experience when we first started using neratinib, it was a good example, was that, people got diarrhea. I wonder if that's me.
It is, but that's
I don't
okay.
know how to
It's the mouse.
There. Okay. Oh, it's the mouse. Mm-hmm. It has a little mouse on it, just for everybody to know, with whiskers. So, the thing is that I learned that, and I had talked to that patient about it, and given her Imodium, but she didn't take it, the loperamide. But in this situation, we're very careful about instructing patients. It doesn't happen as rapidly as neratinib, but it's definitely happening in the first 2 weeks. So I say, you get bad diarrhea, just hold the drug, don't take a pill. Call us. Don't worry about missing a pill if you're having diarrhea. Always have loperamide in your purse or pocket or whatever thing you carry with you. Because, I had a patient who went to work, and she's some distance from home, and then she was having diarrhea, but she didn't bring any of her loperamide, and she didn't go out to get it. It's kind of silly things that maybe you can help people. Patient went on a hike in the woods. Like, take the loperamide before you go on the hike. That would be good. So, and if you're one of the things one of my patients taught me was that if you're gonna go out and have a big salad outside, take a prophylactic loperamide. And the other thing is that people think they have to take a whole pill. So I tell everybody, take a half a pill, and then you won't get as constipated. And eventually, over time, we get the right dose of abema and the right sequence of prevention. So maybe it's every other day loperamide, maybe it's a half a pill, and then we reduce the dose. There's a lot you can do.
Absolutely. Dr. Tarantino, how do you help facilitate adherence for your patients? Do you talk about the possibility of dose reduction up front, or do you say, call me before you stop this? How do you handle that?
Well, I do believe that the risk of recurrence itself helps to determine how important it is. And also, now that we have updated data that show what an important benefit we can achieve with abemaciclib, it's important to discuss that benefit. And of course, also discussing that those reductions can help. And even in patients that were clinical trial participants, so selected based on inclusion criteria, more than a third of them required those reductions. So I don't talk about it up front usually, or at least don't recommend that immediately, but I do recommend it as soon as there are side effects that are impairing quality of life, because I do believe that, of course, just as we want to reduce risk of recurrence, we want to maintain as much as possible the quality of life of patients. So many patients end up reducing at least one dose level, and it's fine, it's absolutely fine, but it's important to find that right dose, the right dose of abema, the right dose of loperamide, and of course always recommending standard things like hydration and in general to maintain a good exercise and a good style of life.
Fantastic. Okay, rapid fire. A couple of questions we have coming in. Would you start ribo or abemaciclib for a patient that had already done 2 years of adjuvant therapy, very high risk? So what's your cutoff to going back and adding one?
Right now, I would just stick with the 2 year of adjuvant abemaciclib and not add more.
What about somebody that didn't start it initially? How long do you feel comfortable on somebody being on AI before you add it in?
You mean when the timing of initiation? Mm-hmm. So the trial really allowed 16 months from the time of surgery, the randomization from time for surgery. Patients could have been on endocrine therapy for up to 3 months, at least in the monarchy in terms of initiation. If it was closer to that time point, I think I'll be fine doing that. Too delayed, maybe not making sense. We just don't have that data. But I think on an individual patient discussion and basis, I'll be open to discussing that with my patient.
We're in the Wild West.
Okay. Well, more Wild West. Dr. Rugo, how do you feel about patients that are eligible for olaparib? Are you picking olaparib over CDK? Would you ever use them sequentially? How are you handling that?
The answer is yes, olaparib over CDK, because it's targeted to the, I think, the tumor biology. I think the only exceptions would be somebody whose cancer clearly progressed on platinum, where I think olaparib might be a little less beneficial. But we only really see that in triple-negative disease, so it's not a question. Sequential, yes. I think, we see these people who have, unfortunately, multiple positive nodes after neoadjuvant therapy, and so we'll give olaparib, and then after 1 year, start the abemaciclib. And, in general, people are on board about it because of the high-risk nature of their disease. So I don't have a big problem with it, and I am willing to start that far out, so why wouldn't I start that far out? What I found was after the drug was approved, and I brought it up to patients who had high-risk disease, they were like, what? No. I'm not taking more treatment
fortunately, the incidence of having germline BRCA2 mutations in ER-positive breast cancer with high risk is not as prevalent, but yes, for that patient population, data-free zones, I'll be open to doing that, but just,
okay.
yeah, to kind of just generalize that, I think we don't know the benefit of that or the detriment of that.
Yeah. Dr. Tarantino, yes or no, do you use Ki-67 anymore to pick out these patients?
Absolutely not.
Okay, I love it. And would you have done neoadjuvant chemotherapy in this case?
If there was palpable lymphadenopathy or a biopsy-proven lymph node, then absolutely yes.
Okay.
It's a lobular cancer. I think I was okay with the way it was handled.
Just to qualify the Ki-67, if you have a patient who doesn't fit into cohort 1, but fits into cohort 2, I would give them abemaciclib. So if they were, had a tumor size under 5 centimeters and not grade 3, but had a Ki-67 over 20% and residual disease, then I would give abema. So I still do use it, but in a more limited way.
I do exactly what you do as well. So if you have a smaller tumor size but not grade 3, then I will go and look for a Ki-67 to justify the
But we're not feeling like everybody still needs to have the Ki-67 with the original.
No.
Unlike the original FDA guidance, we're not doing that anymore.
Okay, now we are going to move on to hormone receptor positive metastatic breast cancer and talking about selection and sequencing of therapies. So 68-year-old woman with a history of breast cancer. She was a T2, N2, grade 3, ER positive strong, PR 50%, HER2 1+. She had adjuvant chemotherapy, radiation, and then adjuvant aromatase inhibitor for 4 years before discontinuing because of side effects. She had arthralgias. 5 months later, she developed hip pain, and she had lytic bone lesions. Staging scans revealed not only the bone mets involving spine, hip, and ribs, but also liver mets. And a biopsy of her liver continued to show ERPR positive, HER2 now, BRCA negative breast cancer. So, Dr. Jhaveri, let's walk through some of the data.
Sounds good. Thank you. All right, so talking about CDK4/6 inhibitors, what is their role in the metastatic setting? And this is really just a table summarizing all the data that we have across the 3 CDK4/6 inhibitors that are currently approved, namely palbociclib through the PALOMA studies, ribociclib through the Mona Lisa trials, and then abemaciclib through the Monarch studies. And this is where we saw that across all of these trials, regardless of the menopausal status, we did see a consistent benefit, and the hazard ratios for the primary endpoint, which was median progression-free survival, was consistent or looked similar across all of these studies, suggesting that this is a class effect in terms of deriving the median progression-free survival benefit regardless of what agent was utilized. Now, taking a deeper dive, now we also have overall survival data, which was not really the primary endpoint of these studies, but we have that available through these studies. And this is an example from the Mona Lisa 2 trial, where patients were randomized to receiving ribociclib with letrozole versus letrozole placebo, and you see that there is a statistically significant improvement in overall survival from 51 months in the control arm to 63.9 months. So over 5 years of overall survival, something that we did not see before CDK4/6 inhibitors entered clinic. So very impressive data there. We also saw that in the Monarch 3. This is data that was presented at ESMO Breast this year, which was the interim analysis 2 for overall survival for Monarch 3. This is, again, your first-line trial, but with abemaciclib. Here, again, numerically, we saw an improvement from 54.5 months to 67 months. Hazard ratio is 0.75, but this was a pre-planned interim analysis 2. At this meeting, actually, we did hear the results of the final overall survival results from this patient population that was presented by Matt Getz. And here, again, we see the numerical improvement, which is not insignificant. We see an improvement from 54 months to nearly 67 months. And so this is really a big numerical difference. The hazard ratio is 0.8. Somehow it did not meet the statistical significance. But I'd like to point out that the patient population here, if you think about the first-line patient population for all CDK4/6 inhibitors, this was a smaller patient population size. The sample size was smaller and was a 2:1 randomization. It could be a numbers game, but at least we see that numerically, and looking at the curves that we saw, that there is a benefit seen with overall survival, which was not the primary endpoint. Now, slightly distinct here or different here with the PALOMA 2 study where palbociclib overall survival we're talking about here, the curves are kind of more overlapping, and we did not necessarily see the numerical gain that we saw with other CDK4/6 inhibitors, but this was the first CDK4/6 inhibitor, again, not powered for overall survival. The median follow-up here is 7.5 years. There was missing survival data, which was 13% in the palbociclib arm, 21% in the control arm, and more crossover to CDK4/6 inhibitors in the control arm. Of course, this was the first study, 27% versus 12%. And 10% of the patients continue on palbociclib and letrozole at the 7.5-year follow-up. So really, we don't have a very good understanding of why this could have been happening, but perhaps a few of these factors do make sense. What is comforting to see that at least when we look at the real-world data, we do see that overall survival with palbociclib was seen in this periodic X study before and after the adjustments that we do for these real-world data sets with respect to statistical analyses. And median overall survival was statistically significantly longer among patients who did receive palbociclib with AI alone, both before and after adjustments of these analyses. So one might question, could there be differences between the CDK4/6 inhibitors preclinically, which might potentially explain these differences in overall survival? Certainly preclinically, we think that ribociclib and abemaciclib are a little bit more CDK4 selective compared to CDK6. Could that explain the difference? We really do not have head-to-head trials, with the exception of the Harmonia trial listed here, which is in a HER2-enriched patient population where we're doing a head-to-head comparison of ribociclib with AI with letrozole with palbociclib in that specific patient population. There are no other prospective head-to-head comparison trials for us to really say that one CDK4/6 is inferior to the other. That brings us to our question about what do we do, I guess.
So how do you currently choose among CDK4/6 inhibitors in the first-line setting, and has your practice changed, Dr. Tarantino?
I do feel that the discrepant results between PFS and OS kind of challenge also our idea of these drugs, because we really saw the same consistent as a ratio, almost a halving in the risk of progression with the 3 CDKs, palbociclib, ribociclib, abemaciclib. We were expecting the same in terms of overall survival, whereas we do see different results. And they had an impact on guidelines. NCCN guidelines list ribociclib as the preferred agent. And I do believe that currently with the data we have, the data is mostly supported by the data. At the same time, we also have to discuss with the patients all of these complications, all of these differences between the trial, and also the difference in toxicities. So sometimes a patient that has a baseline comorbidities that may make it complex, for instance, cardiologic comorbidities may make it more sense, there may be more sense in utilizing abemaciclib. They have got an important numerical advantage in overall survival. And so I do believe that there is a role also for the other CDK4/6 inhibitors, but ribociclib definitely has got the strongest data, to my opinion.
Yeah, absolutely agree. So let's go back to our case. She did start therapy with fulvestrant and palbociclib and had a good response, but she developed progressive fatigue after 12 months of therapy. And what would you discuss with this patient, Dr. Jhaveri, in terms of fatigue she's been on for 12 months?
Yeah, so I think, sometimes when we talk about grade 3 toxicities and we just talk about otherwise low-grade toxicities and we club the low-grade toxicities of grade 2 with grade 1 can be very tricky because an intolerable grade 2 can be as significant for a patient as a grade 3 or 4 toxicity. So if a patient is really struggling with progressive fatigue or a intolerable grade 2 toxicity, I would think about dose reduction and consider that for a patient.
Yeah, absolutely. So this is the patient-centered dosing initiative. It's a very busy slide, but essentially on the left, it was a patient survey. 1,221 patients that had metastatic breast cancer. On the right, an oncologist survey, 119 U.S. oncologists, and really just talking about physician estimates. 47%, required a treatment-related adverse event, had to go to the hospital, had to have a treatment break, et cetera. And then really asking patients how they feel about dosing. And 86% of patients reported experiencing a significant treatment-related adverse event from their perspective. Really talking about mitigation strategies, showing that 83% of patients, when dose reduced, felt that they did feel better on that dose reduction, and 92% saying that they do want to talk to their physicians about dose reductions really to improve quality of life. So I think this is important for us to keep in mind.
And that whole project, just to interject, is such an amazing project led by a group of patient advocates who brought in a group of physicians, which I was really honored to participate in. And that data not only was a platform presentation, a huge amount of work for the group, particularly our advocates, and then was a publication actually by Ann Loser.
Yeah, fantastic. So fulvestrant and palbociclib, she develops asymptomatic progression in the bone, but she does have 1.5 centimeter new liver lesions. And ctDNA reveals both an ESR1 mutation and a PI3 kinase mutation. So we're trying to make things a little complicated for you tonight, trying to keep you awake. Assuming all the options below would be approved or available, which next treatment would you recommend for this patient after progression on the palbociclib fulvestrant?
Okay.
I have no control over the music. Okay. Lots of answer choices apparently took a long time to read through and answer.
I think so.
Okay, so we have most people saying that they would pick elacestrant, over a quarter saying that. Next up is fulvestrant with capivasertib, so being swayed by the new data, and endocrine therapy and alpelisib. So successfully, people are picking out therapies appropriate for this patient's alteration, I think. Do you have a comment, Dr. Rugo?
Yeah, this is a patient who relapsed within 6 months of her last dose of an aromatase inhibitor. Mm-hmm. So in that situation, although we want to give a CDK4/6 inhibitor first, I might do NGS also at that same time, whereas I don't normally if a patient's going to start an AI and a CDK4/6 inhibitor. We'll hear data on Friday morning that will be presented by our very own Dr. Jhaveri, who about a trial where patients who had exactly this situation with a PI3 kinase mutation were randomized to receive a PI3 kinase inhibitor with palbociclib and fulvestrant versus placebo, and that drug is inavolisib. And by the press release, it showed a significant improvement in progression-free survival. So this may really change our way of entirely how we think about patients in this early relapse setting.
Yeah, I agree. This case is a little bit unusual because she relapsed, very close to AI, but then did very well on first-line fulvestrant palbo. So, a little bit.
You wonder if she was taking the AI. That's the main thing.
That's a good point. Okay, continue.
I will. Okay, so just looking at those list of options, you can tell how complicated it is to figure out what patients should really be recommended for, or what should we think about giving a patient population. So let's talk about, should we continue CDK4/6 beyond progression on a CDK4/6 inhibitor, and what did we learn from all the trials that have been reported and what trials are coming our way? So this is the phase 2 MAINTAIN trial, and this study was looking at the question of when a patient has an AI and a CDK4/6 as a first-line therapy predominantly, when you switch the endocrine partner and when you switch also a CDK4/6 inhibitor, is there a benefit to that approach in the second-line setting post-progression? So these were patients who predominantly got palbociclib, about 87% of them, predominantly got AI, and then were randomized to a ribociclib switch and a switch of the endocrine therapy, predominantly getting fulvestrant. Some had AI as well, versus placebo with endocrine therapy switch. And the primary endpoint here was progression-free survival. And with this approach of where you're switching both the endocrine partner and the CDK4/6 inhibitor, you see that there is an improvement in progression-free survival from 2.76 months to 5.29 months with a hazard ratio of 0.57, which was statistically significant. This is a phase 2 study, certainly really gave us more to think about here, and also confirmed some retrospective data sets that we also had suggesting that there might be a role for continuing CDK4/6. Those retrospective data sets were with abemaciclib. Unlike this, when we look at the PACE trial, here the concept was when a patient's tumor is progressing on an AI and palbociclib, if we continue the same CDK4/6 inhibitor and just switch the endocrine therapy partner, would we see a benefit here in that case where you're just switching the endocrine partner? They also had an interesting arm, a triplet arm of fulvestrant palbociclib with a checkpoint inhibitor, in this case avelumab, with a 2:1:1 randomization for the doublet arm getting 2:1:1, where the triplet arm is in the middle here, and fulvestrant alone is the third arm. And here you see that when you compare the fulvestrant to fulvestrant plus palbo, you really do not see the same benefit you saw in the MAINTAIN study. It was an interesting signal that was seen in the triplet arm, which needs further exploration of what this means for our patients and how should we study that more. Similarly, in the PARMIRA trial, which was another trial, again, similar concept where they just switched the endocrine partner but continued the same CDK4/6 inhibitor, we did not see a benefit in that approach. So what do I do in clinic? Do I start using a CDK4/6 inhibitor beyond progression for my patients where I don't have a biomarker perhaps? In an individual patient, perhaps I've done that, but I have not been doing that routinely. What I'm really eagerly waiting for is data from randomized phase 3 trials such as post-MONARCH, which is going to address that question with abemaciclib. We have other trials such as EMBER-3. We'll talk about that briefly. It's an oral SERD and has a cohort of patients with SERD plus abemaciclib. And then we also have a new trial with a novel serum, ELAINE-3, with lasofoxifene and abemaciclib in ESR1 mutant tumors. So I'm waiting for those phase 3 larger data sets to inform my clinical practice at this point. Talking about ESR1 mutations, one thing that I would really want to highlight first is that these, unlike PIK3CA mutations, are subclonal mutations. And so for us to really capture them, I think the best way to capture them is through a liquid assay, a ctDNA assay, because when you have subclonal mutations, you want to try and get all of the information from all the tumors rather than just a needle biopsy from one tumor, which might not necessarily pick up the ESR1 mutation from the other sites that might have this. So this is the data suggesting that the ctDNA testing identified more ESR1 mutations than the contemporaneous biopsies, and different metastases may develop different resistance mechanisms, and this is what a ctDNA assay is supposed to do. And so why do we need newer agents when we already have fulvestrant potentially that could help? I think we have limitations with our current agents. We have limitations with their PK profile. We have limitations with not being able to get benefit in all ESR1 mutations. And there are so many newer novel endocrine agents with different distinct mechanisms of action with an ultimate goal of really downregulating the estrogen receptor with an agent with an optimal therapeutic index and improved efficacy. So all of these efforts have a common goal. It's just that they're trying to get there in different places through different mechanisms, which might be slightly distinct, but the goal is the same. And the very first one that we have is based on the data from the phase 3 EMERALD trial, which looked at LSS-trend versus physician choice endocrine therapy. These were patients who did not have more than 2 lines of endocrine therapy, no more than 1 line of chemotherapy, with dual primary endpoints of progression-free survival and intent to treat patient population and in the ESR1 mutated tumors. 20% of these patients had prior chemotherapy. About half of these patients had 1 line of prior endocrine therapy. And here you can see that the benefit of LSS-trend was seen in both overall and ESR1 mutated tumors, but it was deeper and better in the ESR1 mutated tumors. More patients were progression-free at landmark analyses at 6 and 12 months in the LSS-trend arm compared to the physician choice therapy arm. And with respect to overall survival, I think these data are not yet mature, and we need longer follow-up to be able to further appreciate whether a novel endocrine agent can really, really cause a survival benefit compared to our current approved agents as well. When we specifically looked at the comparison of LSS-trend with fulvestrant, so those patients who got fulvestrant because it was physician choice endocrine therapy that was allowed here, again, we saw the same benefit, and the benefit was better, again, even in the ESR1 mutant tumors compared to the delta of benefit that we saw in all patients. This was an interesting analysis presented by Virginia Kaklamani at this meeting last year. And here, what they showed was that if a patient is on a CDK4/6 inhibitor in the first-line metastatic setting for a longer duration of time and also has an ESR1 mutation, which is really a surrogate of ER dependency for this endocrine-sensitive tumor, single-agent LSS-trend yielded a median progression-free survival of 8.6 months compared to 2 months in the standard of care arm. So really, this is just trying to tell you for the right patient population, this is really a very appropriate therapy. And this is also very safe. When you look at the safety summary, most of the adverse events that were reported were predominantly nausea, which were low grade. And when you think about the discontinuation rates from nausea, they were very, very low. Patients requiring antiemetics for nausea were very, very low as well. Dose reductions were very, very low as well. So favorable toxicity profile, certainly improvement in progression-free survival that we saw that led to its approval this year, and we have that available for our patients now. There are other SERDs being developed. This table is not meant for any cross-trial comparisons here. This is just to provide context and summarize the data. SERENA-2 is looking at camizestrant, which is another oral SERD, also in phase 3 trials, including adjuvant studies. And EMBER is looking at imlunestrant, again in phase 3 trials, both in early and late stage. And what the signal we're seeing, there are distinct patient populations. Some might have more CDK4/6 inhibitors, some might have more chemotherapy. But what we're seeing is that there is a benefit post-CDK4/6 inhibitor, and that benefit can be even better in the ESR1 mutant patient population across these trials. We've started combining these oral SERDs with other targeted therapies, including CDK4/6 inhibitors. This was data we presented last year for imlunestrant with abemaciclib. And here we see that when imlunestrant was combined with abemaciclib with or without an AI, the 12-month PFS rates were similar for the doublet or the triplet arm. There was not an increased rate of safety issues that we had seen. There were no drug-drug PK interactions. And I'll be updating this data set and presenting that data actually tomorrow at a poster spotlight for this combination and updated data from monotherapy for imlunestrant as well. And EMBER-3 is the phase 3 trial that is currently fully enrolled, and we're awaiting the results to see whether imlunestrant will also yield benefit in this patient population after patients have had aromatase inhibitors with or without a CDK4/6. And Arm C is going to evaluate the benefit of imlunestrant plus abemaciclib in this context as well. We presented data for other targeted therapy combinations with imlunestrant at ESMO this past 2 months ago, I guess, October. And here you look at the Kaplan-Meier curves for imlunestrant with everolimus, and you see the median progression-free survival is about 16 months. And when you combine it with alpelisib in this small patient population of 21 patients, the median progression-free survival is 9.2 months. These are the waterfall plot from that, and the response rate in the everolimus arm was 21%, response rate in the alpelisib arm was 58%, and clinical benefit rates for both these combinations was 62%. And these are some select phase 3 trials that are currently evaluating the SERDs with novel targeted therapies. So we have elacestrant that is already approved. Elevate is a trial that is looking at various combinations, including everolimus, alpelisib, ribociclib. We have 2 phase 3 trials. We have the Evera trial that is looking at giredestrant with everolimus and compared to physician choice endocrine therapy with everolimus. And then we also have the Pioneera trial, which is looking at giredestrant with a CDK4/6 versus fulvestrant plus CDK4/6 inhibitor. So a lot of efforts ongoing in late phase, as you can see, to see if the benefit with combinations can be also determined, and then we can offer combinations for these patients as well. So this was post-CDK4/6 inhibitors we were looking at. What about if we start using them in the front-line, first-line setting? Would we delay the emergence of ESR1 mutations and further improve outcomes? Such efforts are ongoing in phase 3 trials, including in the Persevera trial with giredestrant plus palbociclib versus palbociclib letrozole, giredestrant, palbociclib, and letrozole matched placebo versus letrozole placebo, and giredestrant matched placebo. And then Serena-4 is doing that with camizestrant. Again, the same concept. Can we replace the frontline therapy with oral SERDs up front? Novel SERMs have entered clinic. This is one example with lasofoxifene. We saw ELAINE-1 data, which is on your left hand, the Kaplan-Meier curves. This was looking at patients who were at least for 12 months on a CDK4/6 inhibitor and have ESR1 mutations, and then were randomized to receiving lasofoxifene versus fulvestrant. And you see a numerical benefit here for this particular patient population. 4 months PFS in the fulvestrant arm, 6 months in the lasofoxifene arm, did not meet statistical significance, but impressive to see that a result. On your top right are results from the ELAINE-2 trial, looking at lasofoxifene with abemaciclib. Again, a very small cohort of patients, 29 patients, but when you look at this combination, it gives a good clinical activity signal. Overall response rate is about 50%, and median time to responses and the median progression-free survival look very attractive as well. Median progression-free survival here is 13 months. And this has really led to the effort for phase 3 ELAINE-3 trial that I was referring to, which is going to look at ESR1 mutant tumors, and we're going to randomize patients in the second-line setting to lasofoxifene abemaciclib versus fulvestrant abemaciclib, and this trial is currently ongoing. Other agents are PROTAC. PROTAC are proteolysis targeting chimera. Essentially, the mechanism is it not only targets the estrogen receptor, but also an E3 ligase with an idea of ubiquitination and proteasomal degradation, so causing antagonism and degradation. And the first drug here is vepdegestrant, and this is data from a phase 1 trial where we see that despite median 3 prior lines of therapy, the overall response rate is about 12%, and median progression-free survival is 5.5 months in the ESR1 mutant patient population. And we have several phase 3 trials currently ongoing, including single-agent vepdegestrant plus palbociclib in the first-line setting, and then we have TACTIV-E, which is looking at vepdegestrant with everolimus as well with this molecule. And the last molecule I'll mention here is a CERAN, or a complete estrogen receptor antagonist, and a SERD. And so when we think about tamoxifen, we think that it inhibits the AF2 domain, but not necessarily the AF1 domain of the estrogen receptor itself. Here, the idea or the thought is that maybe a complete estrogen receptor antagonist can inhibit both the AF1 and AF2 and potentially have a benefit from that regard. And this is data from a phase 1 study. This was actually updated by Nancy Lin at the ESMO meeting at a poster spotlight. This is data from the 120 milligram cohort. It was an 86-patient cohort, and very pre-treated patient population. Majority, about 44%, had 3 or 4 lines of therapies in the metastatic setting here. And you can see that with respect to toxicity, you do see some GI toxicities with this class of drugs. A unique toxicity signal that we saw with this drug was neutropenia. About 6% of the patients had a grade 4 neutropenia, which was transient and approximately happening around 4 to 6 weeks of initiating therapy. There is no increase in neutropenia when you're trying to combine this drug somehow with palbociclib. There's no PK-PK interaction, and so that's comforting, and maybe the timing is why this is happening, but this was an interesting signal that we saw. With respect to efficacy, we see that the clinical benefit rate is about 40 to 50%. The ESR1 mutant patient population, the clinical benefit rate was about 52% in this cohort. These are the median progression-free survival benefits. On the top are the patients with ESR1 mutations. On the bottom are also with, on the right-hand side is with ESR1 mutations. On the left-hand side is all patients. On the bottom are patients who were treated in the second or third line setting, the way we have with the EMERALD trial. And when we look at that particular patient population treated in the second or third line setting, the median progression-free survival in the ESR1 mutant patient population is about 7 months. So OP1250, or palazestrant as we call it, is also being evaluated in phase 3 trials, and those trials are currently ongoing, including with combinations in phase 1 that have begun. So switching gears, so we talked about ESR1 mutations and the breadth of data that we have or ongoing efforts we have. We also have newer data for targeting the PI3K/AKT/mTOR pathway. We have approval for everolimus, we have approval for alpelisib, a alpha-specific PI3K inhibitor. But now we just got approval on November 16th for a AKT inhibitor, capivasertib, which is an inhibitor of AKT isoforms 1 to 3, based on the results of the CAPItello 291 study. And the study design is what is shown on the slide. So these were patients who recurred on or less than 12 months from end of their adjuvant endocrine therapy, did not have more than 2 lines of endocrine therapy or more than 1 line of chemotherapy for advanced disease, no prior SERD, no prior agents of the PI3K/AKT/mTOR pathway. The hemoglobin A1C eligibility criteria was less than 8, and prior CDK4/6 inhibitors were permitted. In fact, 51% were required to have a prior CDK4/6 inhibitor. Patients were randomized to receiving Capiva. This is an interesting dosing schedule. Here, patients get 400 milligrams twice daily, 4 days on, 3 days off, with fulvestrant compared to fulvestrant plus placebo. And the dual primary endpoints for this study were progression-free survival in the overall patient population and progression-free survival in the AKT-altered patient population. What is that AKT-altered patient population? 1 or more alterations in any one of the PIK3CA genes, AKT1, or PTEN loss-of-function alterations. And here are the Kaplan-Meier curves for investigator-assessed progression-free survival in the overall patient population. Improvement from 3.6 months to 7.2 months in the capivasertib arm. Hazard ratio here is 0.60, which was statistically significant. The dual primary endpoint, looking at PFS in the AKT pathway-altered patient population, again, 3.1 month in the control arm to 7.3 months in the capivasertib arm. Hazard ratio here is 0.5, and this was statistically significant. What is not shown here, but I can speak to, is that there was an exploratory analysis done for those patients whose tumors did not have any of these alterations. So overall, 44% had an alteration either in the PIK3CA, AKT1, or PTEN. About 16% were unknown. We don't know what the alteration status is. Either did not have good tissue, and we could not assess, or the DNA quality was not good. And when we focused on that non-altered patients and excluded the 16% unknown, the median progression-free survival hazard ratio was 0.79. And I think just looking at all that data, currently what we have approval for actually is the AKT pathway-altered patient population. This is the safety data from the CAPItello 291. I think the most important thing that we want to remember as we now are going to begin to start using this agent for our patients in clinic is that the most common toxicities are diarrhea and rash. The grade 3 diarrhea rate here was 9.3%, and the grade 3 rash rate here was about 12%. Hyperglycemia rates, compared to what we've seen with, say, alpelisib, a PI3K inhibitor, here, at least in this study, was 2.3%, so lower hyperglycemia rates. Stomatitis grade 3 was also 2%. So as I was saying, the FDA approval is for patients with HR-positive, HER2-negative, locally advanced or metastatic breast cancer with 1 or more PIK3CA, AKT1, or PTEN alterations, and a companion diagnostic that was approved to detect this with this regimen with the FDA was the Foundation 1 tissue-based assay.
Okay, so let's head back to the case. Remember, this was our patient that had both an ESR1 mutation and a PI3 alteration. And what would be your pick? Dr. Tarantino, I'm going to come to you first. How would you select here?
Well, it is a tricky situation, and we don't have much data guiding. It's a cross-trial comparison. What we know is that there is a differential toxicity profile among the regimens, and so I would definitely be inclined to discuss all of the options with the patient, but the one that seems, by cross-trial comparison, something we should not do, but I'm doing right now, the one that seems more tolerable is elacestrant, and in the presence of an ESR1 mutation and a benefit on CDK4/6 inhibitors, I would favor elacestrant in this case.
Absolutely, I agree. Okay, let's poll. Let's see what everyone else is thinking. Hopefully it doesn't take forever this time.
Now everybody knows all of the things. It's still doing it.
Your mouse loves to move.
What?
Your mouse loves to move. Okay.
Okay. So we have many more people saying elacestrant now, over double, in fact. We also have a little bit more fulvestrant and capivasertib. Great, fantastic. Okay, so she does receive elacestrant. This is followed later by exemestane and everolimus. Then she receives capecitabine, deemed to be endocrine resistant at this point. Her disease progresses again. She has another biopsy. She's still ER positive. HER2 is IHC 1+ now. Assuming all options below are approved or available for you, what would you recommend next for this patient? Our music is getting livelier.
How long did you stay? Yeah, she missed it.
How long did she stay on elacestrant?
It didn't say. She was on elacestrant long enough that she went on to receive exemestane everolimus next, and then went to capecitabine.
With her PIK3CA? No alpelisib.
Okay, so trastuzumab deruxtecan wins the show here. Sacituzumab govitecan comes in second. Okay, Dr. Tarantino, we're going to hand it over to you, but I have a 10-second question for Dr. Jhaveri. Would you ever think about a CDK4/6 inhibitor in somebody that's premenopausal and won't do ovarian suppression, so wants to be on tamoxifen?
Would I do a CDK4/6 without ovarian suppression with tamoxifen? So there is some.
So AK can't get on AI, right?
Right. So there's data with abemaciclib to combine with tamoxifen. Certainly, we have to educate the patients about slightly more increased toxicities that you can potentially see. With that, we've seen a slight more prevalence of venous thromboembolism with the combination of tamoxifen and abemaciclib, but certainly that could be something that would apply. It doubles the VTE rates to 4 to 5%. So short of that, I think at least we have that data and we can apply that. And while in Mona Lisa 7, we actually did officially study the combination of tamoxifen with ovarian suppression and ribociclib, given the increased QTC prolongation, we do not have an approval for that combination, and that is not something that we necessarily utilize in clinic as often, especially because of the concern for QTC prolongation. But say if the other option was not there, that could be a discussion one can have.
If you, and this patient had palbo early on, but there was a Japanese study recently presented that looked at palbociclib and tamoxifen in the Japanese population and showed really very nice efficacy and beautiful safety. So I think that if somebody was going to take, determined needed to be on tamoxifen, OFS or not, I would use palbo myself, because that's where the best safety data is.
You wouldn't use abemaciclib, is that what you're saying?
With tamoxifen, I gave tamoxifen to a patient, she had a pee, 2 months later. So when I give it, when we need to give that combination for whatever reasons, I usually try and use something for anticoagulation. People have said to me, but the rate's only 4 or 5%. I'm like, but that's in a study population. In your clinic population, all bets are off. So I'd rather give something, and it might be to take
baby aspirin.
Baby aspirin every day.
Yeah, I've done that.
Yeah, so.
Okay, Dr. Tarantino, take it away.
All right, let's switch gears. We're going to talk of something very different now, which is how we treat patients after progression on several endocrine treatment options. We know that usually, unfortunately, endocrine resistance develops. Sometimes it's after 1 or 2 lines. Sometimes you can still use 4 or 5 lines of endocrine manipulations. But in the end, sometimes you have to move. Most of the times, you have to move to something different. And for decades, we were stuck to chemotherapy as something different. That works, of course, but it does come with toxicity. toxicities, and it does not work for a prolonged time, and that is why we seek for something better than traditional chemotherapy. And one way to seek at that is through HER2-targeted treatments. We know that HER2-targeted treatments are highly effective in 15% of patients with metastatic breast cancer that have HER2-positive disease, but since even among patients with HER2-negative disease, you have most of them that still have some HER2 expression, even if we call them HER2-negative. We know that this is a heterogeneous group that includes patients with HER2-1+ disease, 2+ non-amplified disease, or even 0. And so the idea is that can we target this low expression of HER2 that does not qualify for HER2-positive, is not amplified for the oncogene, but still HER2 is present by immunohistochemistry? One adjuvant trial asked the question if we could add trastuzumab to adjuvant chemotherapy in patients with HER2-low early breast cancer to improve prognosis. HER2-low means HER2-1+ or 2+ non-amplified. In this trial, NSABP B47, after randomizing 3,000 patients to chemotherapy with or without adjuvant trastuzumab, the adjuvant trastuzumab really did not help, did not improve invasive disease-free survival or overall survival, neither numerically nor statistically. Really saying that in HER2-low disease, the disease is not driven by the HER2, but still we can target it with novel agents. And these novel agents are antibody-drug conjugates. For sure, you've heard about this class of drugs before. How do they work? They're basically antibodies like trastuzumab or different antibodies linked from molecular linker to a highly potent cytotoxic, a chemotherapy. And basically, the idea is to improve the delivery of chemotherapy. When I say improve, I mean reaching the tumor cell more selectively, but also changing the kinetic of the chemotherapy to make it prolonged and make it work better. And the first ADC to really show activity beyond HER2-positive disease was trastuzumab deruxtecan. This is basically trastuzumab linked to a cleavable linker to 8 molecules of DXd. That is a highly potent topoisomerase inhibitor. And when it was tested in a phase 1 trial in several cohorts, including a cohort of patients with HER2-low breast cancer, which represent most of the patients with HER2-negative breast cancer, well, the activity of this agent was very interesting. Among patients with mostly hormone receptor-positive HER2-low or HER2-negative with lower HER2 expression, pretreated with 7.5 lines of chemotherapy, TDXd achieved a response rate of 37% with a median PFS of 11 months. Really remarkable. And this led, first of all, to rethinking the targetability of HER2-negative breast cancer. We used to think that we could only target HER2-positive, only 15%, but now there is an additional 50 to 60% of the pie chart of all patients with metastatic breast cancer that we can actually target thanks to trastuzumab deruxtecan. This was still an hypothesis because it was phase 1 data and required confirmation in a phase 3 trial. And it's important to remember that HER2-low as a biomarker is strongly linked to hormone receptors. And in particular, what we found when we looked at the large cohort of more than 5,000 patients at Dana-Farber is that the higher the estrogen receptor expression, the higher the likelihood of the tumor being HER2-low. So if you look among patients with ER-negative, HER2-negative tumors, meaning triple-negative tumors, about 40% still are HER2-low, have lower HER2 expression. But if you move up, increasing ER expression, and you reach the highest expressors, you have 2/3 of patients with ER more than 95% that are actually HER2-low. So the confirmatory phase 3 trial for this paradigm was DESTINY-Breast04. And this was a phase 3 trial for patients with HER2-low, 1+ or 2+ish negative metastatic breast cancer that have previously received endocrine treatment and 1 to 2 lines of chemotherapy. Most of these patients were hormone receptor positive, although there were some patients also with HR-negative disease, triple-negative HER2-low disease. Patients were randomized to trastuzumab deruxtecan or traditional chemotherapy, meaning capecitabine, eribulin, gemcitabine, or a taxane. And 713 patients were randomized. In the end, 557 were randomized to 2-to-1 to TDXd versus chemotherapy. The most commonly prescribed chemo was eribulin. You can see here the updated PFS curves that we saw this year at ESMO 2 months ago, and it was striking to see a doubling of progression-free survival with trastuzumab deruxtecan compared to traditional chemotherapy. And so with chemotherapy, you achieve a progression-free survival of a little above 4 months, but with TDXd, we really pushed this to 9.6 months. And if you look at the curves, there is a landmark analysis at 2 years. At 2 years, among the patients that received received chemotherapy, none was free from progression, whereas with T-DXd, still there was a meaningful amount of patients, 15%, that were free from progression, really showing how impactful T-DXd can be, even if there is no amplification of the HER2 gene. And this was both in the hormone receptor positive cohort, 90% of the patients in the trial, but also among all patients included in the trial. And most importantly, if we look at the exploratory analysis only among patients with triple-negative HER2-low disease, what we see is, once again, an improvement in progression-free survival. On the right, you can see it, from 2.9 months with chemo up to 6.3 months with T-DXd, more than doubling, and also overall survival from 8.3 to 17.1. This is exploratory. Very few patients, only 58, were randomized, but I think it is consistent with what we have seen with T-DXd, that it's really effective in patients with HER2-low breast cancer. When we talk of side effects, it is a selective delivery of chemo, but it still comes with chemo-related side effects. And so with T-DXd, we still saw up to 70% or more rates of nausea, any grade, although only 5% grade 3 or higher. But also fatigue, also alopecia can be observed, neutropenia. So it's important to remember that disease chemotherapy, and it comes with chemo-related side effects, sometimes even more than traditional chemotherapy, although we are learning how to manage this side effect much better than we knew before. And so nowadays, we wouldn't see in clinical practice 70% rate of nausea because we utilize mostly a 3-drug prophylactic regimen for nausea and vomiting up front. And we know that this is a highly metogenic regimen for NCCN guidelines, and so it is important to utilize at least a 2-drug, but it's even better 3-drug regimen up front. And so based on DESTINY-Breast04, T-DXd was approved last year for patients with metastatic HER2-low breast cancer that have received a prior chemotherapy in the metastatic setting or developed disease recurrence during or within 6 months of completing adjuvant chemotherapy. 2 hours ago, I had the chance to present this real-world data with T-DXd, which basically show that the benefit of T-DXd is dependent on HER2 expression, and so we know that the activity of T-DXd is highest in patients with HER2-positive breast cancer, but still there is meaningful activity in patients with HER2-low breast cancer, and even in HER2-zero breast cancer. Both in this analysis and in the DAISY trial, we see some activity. And finally, it's important to remember that HER2-low is a dynamic biomarker. If you don't find HER2-low on a primary breast cancer, it can still appear, the tumor can still become HER2-low if you do a biopsy in the metastatic setting. And in our analysis, we looked at this evolution. We found the highest activity of T-DXd among patients with stable HER2-low expression along the disease, but still meaningful activity for patients with changes. So we tend to use T-DXd if there is at least one biopsy that tested HER2-low in the past. Shifting gears from HER2-targeted ADCs, that was T-DM1 and T-DXd were basically a proof of concept that we could deliver significant benefits by delivering chemotherapy in a more selective way to patients with metastatic breast cancer. And so we thought that we could potentially expand that beyond HER2 as a target. And a highly appealing target is TROP2. TROP2 is expressed by more than 90% of all breast cancers, at a high degree by more than 50% of all breast cancers of any subtype, and there is a differential expression of TROP2 in the tumor compared to normal tissues, and also we know that it's an internalizing antigen, which is important because we want that when the ADC reaches the tumor, it does not only reach it, but it also gets internalized in the tumor cell to deliver the chemotherapy. And TROP2 was first, agents targeting TROP2, antibody-drug conjugates, were first developed a few years ago. The first one was sacituzumab govitecan, and this basically similar in the structure to T-DXd. You have an anti-TROP2 antibody, that is the sacituzumab part, and then you have a molecular linker that allows it to link to 8 molecules of a chemotherapy, a topoisomerase inhibitor, the govitecan. The govitecan is basically SN38. There is a metabolite of irinotecan. And this was tested first in a phase 1 trial that led to the approval in triple-negative breast cancer, and also in the ASCENT trial that led to the approval in the regular approval in metastatic triple-negative breast cancer. But seeing a benefit in metastatic triple-negative breast cancer made us think that we could bring that benefit also to hormone receptor-positive disease. And the TROPiCS-02 phase 3 trial was was aimed to confirm this benefit not only in patients with triple-negative disease, but also the largest subgroup of patients with metastatic breast cancer that have hormone receptor-positive disease. TROPiCS-02 was a phase 3 trial for patients with metastatic breast cancer that was hormone receptor-positive, patients that have received at least one endocrine therapy, a taxane, CDK4/6 inhibitors, and at least 2, but no more than 4 lines of chemotherapy for metastatic setting. Patients were randomized to sacituzumab govitecan or treatment of physician choice. It could be capecitabine, vinorelbine, gemcitabine, Ribelin, primary endpoint, progression-free survival. When you see the demographics, there's a busy table. We don't have the time, but I think it's important to note that patients received a median of 3 prior lines of chemotherapy, and nearly all the patients had visceral metastasis. And what we saw in this population is that sacituzumab govitecan led to a significant improvement both in progression-free survival and overall survival compared to traditional chemotherapy. Progression-free survival was numerically improved from 4 months to 5.5 months, statistically significant, and overall survival was improved from 11.2 months up to 14.5 months. And this drug is now approved since this year for treating patients with hormone receptor-positive metastatic breast cancer that have received endocrine-based therapy and at least 2 additional systemic therapies in the metastatic setting. And when we say metastatic systemic therapies, we mean chemotherapy or ADCs. And beyond sacituzumab govitecan, there's a full set, many other TROP2 targeted ADCs that are in testing. The other one that is in advanced phase of testing is datopotamab deruxtecan. And as the name suggests, it is a cousin of trastuzumab deruxtecan. You have a different antibody that is datopotamab that targets TROP2. You have the same payload and linker, the DXd deruxtecan. And we have a different drug-to-antibody ratio. In this case, we have 4 molecules of DXd linked to each antibody. This drug is shown in phase 1 trials to be highly active for treating patients with metastatic triple-negative and hormone receptor-positive breast cancer, and this led to the design of the TROPION-Breast01 trial. This was a phase 3 trial including patients with hormone receptor-positive, HER2-negative, IHC 0, 1+, 2+-ish negative breast cancer. Patients were previously treated with 1 to 2 lines of chemotherapy and also endocrine treatment, and were randomized 1-to-1 to datopotamab deruxtecan or investigator choice of chemotherapy with dual primary endpoint, progression-free survival, and overall survival. And what you can see is that most of the patients had received 1 prior line of chemotherapy. That was the median. There were some patients with 2 prior lines, and 90% of the patients had received prior CDK4/6 inhibitors. In this population, there was a significant advantage in progression-free survival with datopotamab deruxtecan compared to physician choice of chemotherapy. You can see that the progression-free survival was 4.9 months with chemotherapy, 6.9 months with datopotamab deruxtecan, and the curves diverged very early, and the hazard ratio was 0.63. Response rate also was in favor of datopotamab deruxtecan. It moved from 22% with chemo up to 36% with Dato-DXd. Overall survival is immature, and we're waiting for longer follow-up, although the hazard ratio is trending toward favoring Dato-DXd, 0.84. And once again, we're waiting both for more follow-up and also for correlative analysis, because we know that these are selective, the targeted agents, ADCs, but in many cases, we're not seeing that the target, the amount of the target on the tumor cell predicts the benefit. In TROPiCS-02, for instance, we saw a benefit with sacituzumab govitecan irrespective of TROP2 expression, and we're going to wait to see if the same happens with datopotamab deruxtecan. In terms of side effects, once again, we do see side effects with chemotherapy. With sacituzumab govitecan, we do see side effects similar to irinotecan, and so to SN38. We see fatigue, neutropenia, alopecia, and also with Dato-DXd, we do see some of these, although numerically there were less side effects and less grade 3 or higher side effects with Dato-DXd compared with chemotherapy. We do see in this case some TROP2-related side effects, and so we know that TROP2 is highly expressed on mucosal membranes, and this may be one of the reasons that led to about 50% of the patients in the trial experiencing stomatitis. There is a typical side effect of this agent. Also, nausea was associated with Dato-DXd, and there were about 20% of the patients that had dry eyes. And it's important to remember with DXd-based ADCs, we do see this inflammation of the lung, interstitial lung disease, that in certain cases can be fatal. About 15% of the patient receiving T-DXd and about 3% of the patient receiving Dato-DXd can experience interstitial lung disease, and there have been fatal cases with T-DXd, and with Dato-DXd there was one fatal case in this study. And so it's important to remember that we have to monitor carefully the lung of the patient with scans, CT scans of the chest performed every 6 to 12 weeks while on treatment with T-DXd or Dato-DXd. And with this, I'll give the word back to Erica for continuing the case.
Okay, so this was our case. Oh, goodness. Okay. Assuming all the options below. Oh, okay. So elacestrant, exemestane, everolimus, capecitabine, and now remember that she's 1+. So assuming all of the options below would be approved and available, what would you recommend and why? Dr. Rugo?
She has HER2 low disease, and I think, with the survival benefit we've seen with these antibody-drug conjugates, we would use T-DXd, and I think that that's going to be regardless of the approval of Dato-DXd. It seems as though, the hazard ratio is relatively similar in Dato and SASI, even though median 1 line, median 3 lines, all the caveats and the PFS sort of shifted down a little. But with T-DXd, we're seeing, I think a relatively greater benefit. And I think that, it's kind of a fascinating thing that none of us would have thought that her HER2-targeted ADC would work better than a TROP2 ADC in this specific setting. I mean, I think all bets are off when we talk about triple-negative disease. And also, I think that, in the HER2 zero, as you showed, as you start losing the HER2, things change also. I mean, that was really fascinating that, it's obviously early data and retrospective, but, where you lose the, there was all this study at ASCO about if you kept biopsying, you get more HER2 low, which I personally haven't seen, actually.
Biopsy enough, you will get a low.
I would biopsy the liver. You could biopsy 5 times, still going to be 0. This is my experience with it. But I think that, as you go to 0, you're also losing ER, gaining resistance, and the drug doesn't work quite as well. But I think we would mostly use T-DXd. I will say that in this patient, I don't think everolimus works quite as well as a drug targeted to PI3 kinase, and so I would use a drug targeted to PI3 kinase rather than everolimus in this particular patient, before I got here.
Yeah, I agree. I think that T-DXd, has greater magnitude of benefit and probably a greater duration of benefit, really.
I think you're giving it every 3 weeks. It causes, its primary toxicity is nausea, but I have to say with using olanzapine, we got a lot better at managing the nausea. In the beginning, we were kind of like, oh, it's an ADC like TDM1, and we don't have to worry about it, but now we're much smarter, and we actually changed the NCCN criteria to make it that you could use triple drugs. So we made it highly emetogenic, which some people are unhappy about, but it's been great for the patients, because then you can use triple drugs. You can always take away something. And then we use, again, the low-dose olanzapine that was presented today by our colleague from India, Jyoti Bajpal, and the mini orals, in case you missed it, because she looked at 2.5 versus 10. We only use 2.5. I mean, everybody would sleep for days if we gave them 10 milligrams. And it worked just as well. So this was all really good data. Whereas, you got to deal with the nausea, hair loss, stomatitis with Dato, nausea, diarrhea with SASI, and neutropenia. So not as much nausea, more neutropenia, diarrhea. So.
Absolutely. Okay, audience answer. What would you be thinking about for this patient?
Now that we've told you.
Yeah, right.
Did we finish it already? That's impressive.
Okay, so we have majority saying trastuzumab deruxtecan before, even more saying this afterwards. Okay, our patient receives trastuzumab deruxtecan but develops further disease progression. What would you recommend next? Do you feel comfortable ADC after ADC, Dato, sacituzumab, intervening chemotherapy, or I'm not sure?
Okay, now this one's going to wake people up a little. Yeah.
Okay, we have most people picking sacituzumab. 63%, and about equal for Dato and other chemotherapy. Dr. Tarantino, what do you think here?
I think this may be the hardest question of the night.
I added
and,
one.
and it is the elephant in the room. The fact that we're starting to have many ADCs, and today there was a very exciting session of ADC post-ADC. There were several presenters showing that in real world, the second ADC does not seem to achieve the same benefit of the first. And we know that in general, the more the prior treatments, the least the efficacy, but still, most of these ADCs have got topo-1 inhibitors as payload, and can we use the same chemotherapy over and over through ADCs? It is hard. It is hard, and I think there is no great question, no great answer. I do believe that many people are talking about this sandwich strategy of utilizing a traditional chemotherapy in between ADCs, and I do believe it's not crazy to utilize a taxane. There is a highly effective chemotherapy that works in a different way compared to a topoisomerase inhibitor in between TDXD and sacituzumab govitecan that I will still use for treating these patients. But personally, I prefer to use something that works in a different way.
Yeah, I think it's a tough answer because on one hand, we do have worry about ADC after ADC, but they've beaten standard chemotherapy, and chemotherapy is not giving us a whole lot of benefit, so it's tricky. We're going to have to get more data.
Yeah, I agree. We need more data. I will say that in now a number of series, because we saw one at ASCO, now we saw several here, that there are patients where, in general, the first ADC works better than the second. But then there's this section at the bottom of those little bar plots that show that the second ADC works better than the first one, which clearly has to do with some mechanism of resistance we haven't been able to, test in real time. So I think that using sequential ADCs is a good option for our patients. Whether you want to sandwich it in with a taxane or some other drug, I think is fine. The idea behind the sandwiching is that you would upregulate the receptor, but if you're using a different antibody, that probably doesn't matter as much. And if you've really messed up TOP2,
a lot of things are out the window.
Yeah, I mean, you don't know. And so there was there was an interesting study looking at this and seeing TOP1 alterations, but there was one patient had TOP1 alteration who had the longest course with 3 ADCs. So, it's not 100%, and so we don't have a test yet. So I would say either sequentially, you could add a drug in between, but we don't know.
Great. Okay, so a couple questions, and we're going to end here. Question about why is elacestrant only approved for those with ESR1 mutations if the PFS was also better in the intention to treat analysis? Dr. Jhaveri, do you want to take this one?
Yeah, so I think it's a great question. The trial was designed to look at both, all-comer patient population and the ESR1 mutated patient population. It was not really powered to look at the unaltered patient population or those that did not have the ESR1 mutation. And, when we look at that benefit that we saw in the all-comer patient population, the delta of benefit was really, really small. And so I think it was the idea that it's modest even in the ESR1 mutation, but definitely deeper and better in that patient population. And so to account for that, it was limited to the ESR1 mutant patient population at this point.
Okay, perfect. Last question, because many people need to go to bed. So 13.1 month improvement in overall survival in Monarch 3, is clinically significant, it's not statistically significant. Do you think the lack of statistical significance will impact utilization? And do you think it'll impact reimbursement at all? It's been starting to affect reimbursement for Palbo.
So we could all answer no.
Yeah.
Anybody have a different answer?
No.
No, absolutely not.
No.
No.
Okay, we're unanimous. I mean, it's a fantastic note to end
Big
on.
NO, yes.
So I want to thank everyone. Thank you guys for coming, and thank for our patient advocate groups for partnering with us.
Thank you. Lovely.